Hey, and welcome back to the next episode of the Sequence Podcast. I'm your host, Dr. Spencer Nadolsky, and I have here with me again the lovely Dr. Danielle DonDiego, one of our amazing clinicians at Sequence. Today, we're going to be talking about common side effects of the different weight loss or obesity medications and what we do with them. There's not a lot of guidance. There actually was a review recently about how to kind of deal with some of the nausea and that type of stuff. But we're going to go over because a lot of this stuff is like we're treating it on the fly. This is I don't want to say we're ahead of our time, but because we have so much experience and we have to figure out things that maybe haven't worked from some of the guidelines out there. We're going to go over our experience. So thanks again for coming on, Dr. Danielle.
Thank you. Thanks for having me.
Yeah. The other thing is we talked before about telemedicine as a treatment avenue for obesity. And, so you think about these side effects, but I still think that that's really important because we can really closely monitor people like in real time. So again, if you're in the clinic going to whether it's your PCP, endocrinologist, obesity specialist, whoever that's giving your medicine, they're busy in the clinic and they're seeing people, and you may call and then the MA may tell you and you may get back to it, at some point, maybe not. But we track our side effects pretty closely, and we even have this little thing in the web app where people can track their side effects, and it will actually shoot us a message, and it will automatically give them certain guidance based on what side effect they're having. So like nausea, constipation, whatever, it'll give some general guidance, and then it can even alert us if it's more moderate to severe. And then we can jump in to see like, hey, is this more urgent or whatever? So let's kind of get into it. So the most common, medicines used right now on telemedicine for weight loss are these GLP-1 agonists. We've talked about them before. They're extremely popular in the news. The glucagon-like peptide 1. These medicines work by mimicking this hormone from our intestines. And one of the things it does is that it slows down our gastric emptying. There's certain possible receptors in the brain that may be attributed to nausea. I don't think all of the nausea is exactly from gastric emptying, slowing down. Yeah. But a lot of that, but probably a good amount of it is. So what's the most common thing that you see with these patients? Is it nausea?
Nausea, definitely. And it's the thing that I get the most, pings on telemedicine for. And it's usually within the first 24, 48 hours if they're going to have it. Which again, going back to telemedicine, at least we can manage it in real time. But by far, nausea is the most common. What
do you think percentage? So I'd say that most people will have some mild bit of nausea, but I would say for most people, it's tolerable. Nothing, you don't need to intervene, maybe some guidance on how to eat, changes in diet. But what would you say? Because I always tell patients a certain number. I'd like to hear what you have to say. What is the number of patients that say, I need some medicine or something right now for this nausea? What would you say? One in however many?
I feel like 20% will ask for a prescription level anti-nausea medication. That's just my observation with my patients. There's plenty of, I'd say up to 30 to 40% will experience some kind of nausea. In general, that can be managed either with eating a little bit more often. I find that if people are going long periods of times without eating, on an empty stomach, that contributes to the nausea, in my opinion. But I always say try ginger chews and gum and things like that over the counter. You can use those more often than the nausea medications. We really try to reserve that for severe nausea, vomiting, when you're really not able to tolerate anything PO.
Yeah, I would say, so I always tell patients look, probably majority of people will have just a little bit of nausea. I would say moderate to severe nausea. Yeah, something like 1 in 10. I'd say the severe, oh man, they're not doing well, where we have to intervene. I always tell people around 1 in 20. So you're saying more like 1 in. Do you think everybody that asks for medicine you're oh, they definitely need it, or do you feel like some of those people are maybe?
I would agree with like the 1 in 20 of like severe nausea, like they are having a really hard time and need to stop the medicine. That's not as common, but it does happen. I think a lot of people like to have the prescription as a just in case, because when it happens in the moment, nobody likes that feeling. So I do tend to like prescribe it if they ask for it, but also counsel that, only use this if like nothing else is working or like you feel miserable. But I think there's a lot of fear around the nausea because it's a terrible feeling. Nobody likes to be nauseous.
Yeah. If anybody's had like a gastroenteritis, I mean, it can kind of be like that where nothing sounds pleasant. You're just kind of laid up in your bed, even though like your energy might be okay, but like you're just feeling miserable. Nobody likes to feel like that. So yeah, I'd say like 1 in 10, 1 in 20, something. I'd say more like 1 in 20 where they're laid up. I'd say people that can tolerate it, but they're kind of feeling miserable. Maybe, 1 in 15 or so.
Yeah. A lot of people will report nausea, but say it's manageable. I do have a lot more patients that are in that category than requiring medication. And the medication we're hoping is temporary, like use of like Zofran or something. If somebody's still at that place, like in week 3 or week 4, definitely not going to increase the dosage, because it's only going to make it worse.
Yeah. So I always tell people the majority of nausea will go away, even if it's moderate to severe. This is why it's really key if starting at the lowest dose, if you're what we call GLP-1 naive, like if you're switching from one GLP-1 to another one, that's one thing. But if you're naive, meaning you haven't taken any GLP-1s, always start at the lowest dose. We have people coming in, hey, don't start me. I need to lose a lot of weight. Start me at a higher dose. It's like, no, because we don't know how you're going to respond. I promise you that like, it's so cliche, but it's like a marathon, not a sprint type of thing.
Yes.
And it's so cliche because it's like, yeah, I know, but I want to lose this weight now. And I'm like, I know we have to do this the right way because some people, maybe they won't get weight loss on that first dose, whatever it is, whether it's, semaglutide, tirzepatide, liraglutide, dulaglutide, any of these. But sometimes people respond extremely well to that and they'll lose a lot of weight. You've talked about some of your initial patients on just the lowest dose losing, 20, 30% of their weight.
Yeah.
We're seeing some of that. And at the same time, though, some people have severe nausea just on the lowest, tiniest little dose there is. Well, some people get up to the highest doses and have had no side effects. So we have no idea how anybody's going to respond. I wish we had a little genetic test or some blood test to know. There's no way of knowing. Some people are like, no, I have an iron constitution. I'll be fine. And nope, they were not. And then sometimes, again, people are like, I'm really nervous because I get nauseous with whatever. And they do fine. So I have no way of predicting.
There's no rhyme or reason to it. And I'll often get asked with an initial prescription of how can I prevent the nausea? And I don't have a good answer for them. Yeah. It's a little bit like, I hope you don't get nausea. And if you do, we'll try to manage it, which is a little bit frustrating from our end, but we have no idea why somebody gets nausea and somebody doesn't. Yeah,
we have some, our dietitians, we came up with some dietary guidelines, and we'll have some of the dietitians on the podcast at some point. Generally smaller meals. Like the thing is, if some of it's from the gastric emptying slowing down, if your GI tract is slowing down and there's foods there, it makes you not feel great. So smaller meals, more spread out, let yourself digest. I mean, this is kind of common stuff, but somebody, they'll even come back and be like, I probably shouldn't have eaten that really heavy meal. For me, that would be bad because I'd go and eat tacos and shawarma and all this stuff. And I'd be like, I'd be laid up in bed. But, okay. So ginger, beets, people talk about B6. I don't know if the B vitamin, I don't know if they actually help or not. People swear by it. Alcohol wipes. Yeah. People talk about alcohol wipes. They do. And some people do report that helps them. That is something that I've told people to try. I tend to go with the ginger. I find that is more commonly helps more mild nausea. But and like you said, eating smaller meals and eating them more often, either being on an empty stomach or having a really too full of a stomach. I feel like either end of that spectrum can make nausea a little bit worse. I think it really depends on the person. I don't know. I've seen it where people, if they eat more often, it makes it worse. If they eat, I don't know. I haven't been able to pin it down. It's kind of interesting.
It'd be interesting to see like all the patients that we have of the people that have nausea, like what
Survey
things made
them.
it worse for them. Yeah.
I think we should survey it because I think, we have some general guidance, but I think some people are like, that's weird. That made it worse. Whereas the other way made it better. So
yeah.
So probably if you're listening, you're having side effects, you'll just think about those different variables and how you can try it one day versus the other. The other thing is like most people will notice it's like 1 or 2 days after an injection. If you're on liraglutide, Saxenda, that's a daily, for that one, like we can just take back your dose quickly, like since it's a daily injection. But for the weekly injections, it's like they'll notice it not the day of, but the next day or the next day. And once in a while, people are doing well on it, and it's for some reason the third week they hadn't had nausea. I don't know. They should be getting better.
I've seen that too.
I've
seen that too, and it's not common, but sometimes they're like, I was doing great, and then the third injection, all of a sudden, and I don't know if it's just like the build of week to week to week, and it gets them, but
not sure.
It's odd, and sometimes it's like pretty self-limited at that point, but it can feel pretty awful.
Yeah. So for nausea though, the most common medicine we prescribe is Zofran. That's the brand name. We do ODT, which is oral dissolving tablet, or as we like to say in residency, under the tongue. That's so stupid. But that's all like ODT under the tongue. No, it's not. And actually, the directions say put it on the prescribing the packet insert. It says put it on top of your tongue and let it dissolve. Anyway, it's an oral dissolving tablet regardless. So you don't even have to swallow it. So it can help so you don't have to drink a ton of water or anything.
Yeah.
So that's ondansetron. It's a serotonin modulating drug. Now, there are other anti-nausea medicines. There's promethazine. We don't use that one as much, but it's a possibility. These drugs both may have some interactions with a lot of the medicines you're taking. QT interval, which is something on an EKG that's looking at the electricity timing of your heart. And these drugs can interact with other medicines, and we're very careful with that. So if a clinician's like, hey, I really can't prescribe that, it's not because they're trying to be mean and want you to be feeling bad. We want to be very careful that we're not messing with somebody's electricity of their heart. So
also why it's important to let your doctor know every medicine that you're taking, because we have to look at everything. That's happened a few times where, because it's telemedicine, people are like, oh, I forgot to tell you. Yeah. It's so important that we know what you're on.
Yeah, very, very much so. There are other medicines that we don't commonly prescribe that other clinicians out in the world are doing. There's one called Reglan or metoclopramide. And this one actually increases the motility of your GI tract, but we don't prescribe it often. There's some certain side effects that you can get with this that like we just don't even want to mess with. But that's something that maybe you discuss with your physician.
Not my favorite.
No, I don't like messing with that one. I had one patient that was already on it, and so I did. And the thing is, because it increases the gastric motility, it probably does work. Because of the side effect potential, I don't. So this is why it's very key to stay in a low dose and only go up. Like, so when you have you look at the side effects, like the people, when you're going in for a refill, you probably look at their side effects that they've been having. So let's say, whatever, let's go with on-label prescribing. So let's go with like Wegovy or semaglutide, which hopefully when people are listening to this, it's coming back in stock. But
hopefully it comes back.
let's say somebody's on 1 milligram and they want to go up to 1.7 as the next dose. And, their weight loss is going well, but like they want to go up, but you've noticed that they've had like side effects over the month. They don't say anything in their refill requests. It's that you can just look at their tracker and they're like 2 or 3 nausea, out of 5, let's say. What would you do in that case?
Have people rate out of 5. Yeah. If it's like a 2 or 3 out of 5, I will often actually message the patient and be like, hey, like, how bad is this? How often is it? Are you needing anything to, resolve the nausea, or is it going away on its own? If somebody is like, oh, I have a 2 or 3 out of 5, on the scale, but they're like, but the Zofran takes care of it. I'm like, wait a minute.
Yes.
We don't want that. We don't want you requiring another medicine to stay on the GLP-1. We don't want to overload you with medicine just to tolerate it. That's not our perspective. So, I'll often reach out to them and ask like what's really going on. And sometimes they're like, oh, it's just the day of the injection and then it goes away. And then I'm like, all right, if you're comfortable, you want to go up, we'll try it. But yeah, sometimes I need more information.
That's good. No, that's perfect. That's the thing. So I wanted to touch on, people will ask for refills of their Zofran or on Dancitron. I'm like, whoa, wait a second. Like, maybe we should just not go up in the dose. Like, I told you, you're having an effect on your weight and your appetite. But, people want to go faster, despite having side effects. And the Zofran, like, the goal is to not have to, we don't want to over medicalize, as you said. Drugs have side effects, interactions, whatever. So we want to be careful there. So I like that. That's good guidance. Let's move on. I'd say let's move on to the next most common side effect of the GLP-1s. Okay. What's the next one that you see?
Constipation. Yeah. Yeah. That's going to be that's what I would say.
What do you do for this? Like, I mean, we have our general guidance, but like, what's your
first thing I ask about how much water they're drinking, fiber intake in their diet. A lot of people when they first start these medicines, I never really recommend like an overhaul in your diet right away, right? I'm just kind of like, see how it affects you, but it does depend on the consistency of your diet. If you weren't getting fiber before and you're not getting it on a GLP-1, then I would have you increase fiber in your diet as best as you can, adding things like Metamucil or Miralax. If somebody's going less than every other day, then I say to try something over the counter, like the Miralax, Colace, Metamucil. That's kind of the guidance that I typically give. But I like to ask about water and fiber intake. And oftentimes that's like the first step for me.
Yeah, I think that's perfect. The other thing is when I talk to patients, I preemptively tell them about the nausea, be aware that could happen. And then I talk about the constipation. Because it's hard to prevent the nausea, I think, unless maybe you tell them like, hey, bigger meals, that could probably set it off. But like constipation's the one that I think you could prophylactically tackle. And I tell everybody, increase your water, start walking a little bit more. Obviously, that's like going to help with weight loss, but like, it's easier said than done. We all work and whatever. Yeah. It's like, if you can walk, just try to be active because that gets things going. And then the fiber, Metamucil is probably my favorite. Psyllium husk is the generic. The other thing, so Miralax as needed. You can do stool softeners. I'm not sure if that helps or not, but Orlistat, I've talked about this before.
Oh, that's right. You do. I haven't tried that yet, but I have heard that you have used that for patients.
It's really interesting. We don't have it in our guidance just yet, but I maybe in one of our little blogs, but Orlistat, it's one of the common things that you see as like, that insurances want to see that you've tried, even though it's ridiculous to have to try those before going to one of these more effective medicines. But Orlistat, Xenical is the prescription version, but I tell people to get over-the-counter Ally, which is a lower dose of it. And these things can cause oily stools, loose stools. And so people don't like that, so that's why I don't take it.
It's not the most fun weight loss medicine.
No. So it's a lipase inhibitor, which means lipase is what breaks down the fat so you can absorb it. So it goes kind of right through your GI tract. So if you're a normal person going and taking this, you could get oily, anal leakage, they call it. It sounds gross. It really is. But if you're constipated, it can actually normalize things. So it's kind of an interesting thing. So one, with your meals, you would take one. I've had some patients, it worked too well. One patient was like, I had stool in my pants. So, and they were,
it happens.
They were happy that they were able to start going, but then they were not happy because they, had an accident. So take that for what it is. So be careful if you're going to do that.
Yeah. And, just from like the primary care lens, a lot of people struggle with constipation in general, right? That's something we see a lot in practice. So like if you're coming into this, coming into Sequence or a program for GLP-1 weight loss, and you already struggle with constipation, let your doctor know, because it's good for us to know, like, what is your normal baseline of, of bowel movements. And then what's the change with the GLP-1, because we may need to get ahead of it. And we may need to be very careful about going up on your dosage compared to other people.
Yep, exactly. Next most common thing you see?
It's a toss up between, I have people get diarrhea, but it's only like in the first few days, and then it typically resolves. I have a handful of times had people where it's lasted, and I have no reason why. But it's between that or fatigue.
What about GERD?
Oh yeah, no, that
because I was just thinking about that
for sure.
Yeah,
reflux.
I wonder if that's about in line with constipation. I think maybe similar. Maybe I don't know.
And it makes sense. Like just with the way the medications work, that reflux would be an issue. So
reflux is tough. So it's the same thing. Low, go slow. If you have a history of reflux, be aware that it may get way worse before it gets better, if it ever gets better. So go low, go slow. Eventually gets better. We start with Tums. I don't know. Basically Tums to then go to these H2 blockers, Pepsid. Yeah. Then to PPIs. Now, just like everything else, we don't want to over medicalize. Now we're giving drugs, and now you're on this other drug that, these things can have long-term side. Like if you stay on these drugs long-term, they're associated with all sorts of things. They don't know whether, they truly cause some of these things that you see on the internet, but there's an association there.
Yeah.
But that's generally like small meals. Stay on the lowest dose as possible until it resolves, then go up. Maybe you need to use Pepto-Bismol, maybe some Tums. If that's not working, go up to Pepsid. If that's not working.
And I'll counsel on, your typical GERD lifestyle changes, as in, avoid spicy foods as best you can, avoid acidic foods. Carbonation can make it worse. And the other thing, after you eat a meal, do not lay down for at least an hour. Don't eat and then lay on the couch. Actually laying down horizontally will make those reflux symptoms worse. So just make sure to stay upright. Those are the things that I'd like to counsel on for reflux in general. Yeah. If it's something that's really bad and somebody's needing a higher dose prescription of a PPI, I typically will refer them to their primary care doctor, because I'm like, is there something else going on? Do you have underlying gastritis? Do you have underlying H. pylori? Do you have underlying, do you have an ulcer that we didn't know about? So if it's not managed with simple remedies or dose changes in the GLP-1s, then I try not to treat the GERD full blown in this place. That's
what you did. Is pretty much spot on from what I do. I think it's, so I get random reflux. I don't understand when I've actually had a endoscopy, because I was like, what is going on here? I was like, what is going on?
I drink a lot of coffee, so.
So I thought it was the espresso beans that I don't know what it was, but if after a meal, if I lay down, forget about it. And then I can't, and then it won't stop, because then I'm like, oh, I better sit up. And then all of a sudden it's like, for the rest of the night, I'm like, so anyway, those are good advices. Okay. So next thing we said, diarrhea.
I feel like either diarrhea or fatigue are going to be after that.
All right. So what's your diarrhea management?
Honestly, because it seems to be so self-limited, I just say, hey, stay hydrated. I would say, let me know tomorrow how you're feeling. I've rarely seen it last more than 24 or 48 hours. If it is lasting more than that, I definitely talk to the patient a little bit more. But hydration, and if it's, I try not to recommend Imodium, but if somebody's really miserable, I'll say it's okay to take. But, we don't want somebody, again, over medicating. If your body is trying to get something out, you don't want to stop it. I don't know if people realize that's why we don't recommend Imodium all the time. We want your body to do what it needs to do, but we also don't want you miserable, so we try to manage it. Yeah.
Pepto-Bismol.
That's what I typically tell
Pepto-Bismol treats all of it.
Yeah. Yeah, they could definitely try that. I have seen some patients, not necessarily in the beginning or with a dosage change, get diarrhea after they're like, oh, I ate something really, high in sugar, high in fat, like they went to a birthday party or something, and then they had like a stomach ache the next day. Again, self-limited, but I think that there's something there with GLP-1 that can make, if you do tend to like overeat one time and you haven't been for a while, especially on like higher fat or higher sugar foods, I think can contribute to like a small bout of diarrhea as well.
Yeah. Let's see. Yeah, I do Imodium sometimes, only like rare. It's rare, actually. Rare.
Yeah.
Rarely. It usually resolves over time. So I'd say the next one, fatigue. It's bizarre. And I got in a little bit, not a debate, but not to brag here, not about myself, but about our company. We have more experience than 99.99% of the physicians out there, just the way we practice. And we see the fatigue, and people on the Twitter, the doctors, like, I think it's because they're not eating enough. And I thought that right in the beginning when we started doing this. Yep. But it's not. Partly, some of it maybe, but some of it's straight up the drug. Because the reason I say that is because some people on the lowest dose, they haven't noticed a change in their appetite necessarily. They aren't losing weight. If they're not losing weight, that means they're not changing how much they're eating. They're literally eating as much as they were before the drug. And now they have the fatigue. So it's straight up something from the medicine. And it's rare relatively, but we do see it. Yeah. And I don't. Yeah. What's your guidance there?
That's been hard to counsel because, like you, in the beginning, I thought, oh, they've probably drastically decreased their caloric intake. Like you feel terrible if you don't eat enough, you know? So my initial thought was, be sure to keep eating. And I always try to ask them, like, is that the case? Are you eating like one meal a day? And that's been the case for some people, but like to your point, that isn't the case for the majority of people. And I don't know the mechanism of why this drug would cause fatigue. Yeah. But, again, I try to stick with water. And then if they're still feeling that fatigue towards the end of the month at refill time, sometimes I'll say, hey, do you want to come back down on a dosage? Like, I don't want you feeling terrible. And I don't want somebody like trying to survive on caffeine either. So it's been hard to counsel because we don't know the cause of that.
Yeah. Nobody knows the cause. It's not even reported in the literature. It's not reported in the trials, but we see it. And I don't know, other than time, 99.9% of the patients it's resolved. So I don't know. Yeah. It just takes time.
It does go away.
Maybe I think there was one person that was basically like, I can't take this anymore. I'm just feeling tired. But that's very rare.
Yeah, I agree with that.
What's the next most common? I mean, that's the majority of them. We see some weird stuff. What about menstrual cycle changes?
I haven't had in the beginning, I think I had more people say that. I have not had a lot recently. I don't know if it's just that people are aware. But it can alter your menstrual cycle, but we don't know that we don't believe that it's harmful in any way. Yeah. It's just your period might be a little bit off. So if that happens, a lot of reassurance is really what to do there. There's nothing to change. We don't talk about birth control changes or anything like that. In my opinion, it's just, wait it out.
Yeah. So tirzepatide specifically has in their package insert they're like, use a barrier method or alternative methods for the first 4 weeks.
For contraception.
And also when you go up. If it's oral contraception, but I'm not seeing it's in other patients that don't have a history of PCOS where you see changes in periods, and it's in patients with no other medical history other than obesity and obesity related conditions, and no PCOS. I don't know, and so actually I messaged some of the medical science liaisons, they call them, for these companies, and there's nothing reported in the trials, but we see it. I don't know. Yeah. Kind of weird.
Yeah. And separate, like the menstrual cycle changes versus contraception using a barrier method. That is something that we definitely counsel all patients on, is if either in the first month on a medication or after an increase is when you need to use a backup.
And that's in tirzepatide, but not semaglutide. I wonder why that's not the case, because the mechanism should be similar. I don't know, because if you're changing gastric emptying, maybe that obviously that has to be the concern. So why isn't it in the semaglutide? I don't know. So is it good? I don't know. And I wonder
if they had so many pregnancies reported during trials. I actually haven't looked at that, but
I haven't seen
that. Probably be something to.
That's kind of weird, isn't it? But we just better safe than sorry.
Yeah, we don't want you to have an unwanted pregnancy if that's not on your goal for the year.
And you got to stop the medicine and all that. Any other things? I see sometimes people urinary frequency, kind of weird stuff there.
I've seen that probably less than a handful of times, but I have had people report that. Site reactions. That's something I do see pretty frequently.
Yep.
Yeah. And, is it an allergy? Is it just a reaction? Most patients do just fine with a little bit of hydrocortisone. Benadryl, if necessary, typically goes away. Usually tell them to change the injection site, either from the stomach to the thigh or vice versa. Sometimes that makes it go away. Again, I don't really know the rhyme or reason, because you would think if it was like a pure full-blown allergy that it would get worse every time, no matter where you injected the medicine. Like that would, that's what my thinking would go to, but that's not really the case.
Yeah, it's local versus systemic. Kind of like think about like when you put a Band-Aid on and you kind of get this local reaction. That's kind of similar. So I think
sometimes I'll have.
I had one patient that had a systemic reaction.
Oh, really?
Yeah.
Yeah, I haven't had anyone have a systemic reaction yet. So, we monitor. Like if your reaction is getting worse and worse and worse over every week, then I'll typically say to change.
Mm-hmm.
But if it's like the normal, like just a site reaction and it goes away with hydrocortisone or Benadryl, then typically I'll say you're okay, and I just have them send me photos and keep me updated, or pre-medicate with Benadryl. That's the other thing.
One patient figured out, I think it was semaglutide. There was something in the preparation. It wasn't the semaglutide itself, and they were able to take oral semaglutide and they were fine, but the injection, they were having a reaction, and they looked at the ingredients. I'm like, yes, it's this ingredient I'm allergic to. I'm like, wow. That's rare. I don't even know how you'd figure that out.
Yeah. So that's probably something I've seen more commonly lately is the site reactions,
mm-hmm.
but we also just have a lot of patients. So I think it's also like we're seeing more of everything.
Yeah. We have a very big sample size that helps it helps us, we have to go on the fly. There's no guidance anywhere about this, and it's not even in the trial data, which is interesting. So I think that about does it. Anything else?
Yeah, as far as side effects, I think we've covered most of the things that we see. Anything else is definitely more of an outlier.
Yeah, rare.
But those are the main ones that we see and are comfortable with. And tell your doctor if you're having a side effect. Again, that's one of the beauties of telemedicine is you can tell us that day and let us know. We can help manage.
And we should have some automatic. We have some automatic guidance that should send out, and then if it's moderate to severe, you can alert us and it'll let us know.
Yeah. And I think the other major point is there's a lot of those news articles about people like, you're taking medicine for weight loss. There's like those fear mongering articles out there. And just so everybody knows, your doctors behind the scenes are not trying to over medicate you.
Yeah. No, we are not.
We want you to be comfortable if you're taking these medications, and we don't want it to be miserable, and we don't want to just pile on more medicine for you to get to a scale goal. We really are looking out for your safety before anything else.
Very good. Well, thanks for joining us again. We'll have you back on. We'll go over your experiences.
Awesome. Thanks for having me.
All right.